This talk is about where IR can help in trauma management. So general principles to endovascular management. This is supposed to be a blood vessel, and that's the inside of the vessel. In general, principle is pretty straightforward. The vessel could be injured by perforation or pseudoaneurysm or transection. For example, we may be able to put a covered stent or coil embolize across a defect. The concept is pretty straightforward. It's the execution that can get a little more difficult. Gifts we may leave behind in your patient. So these are fibered coils. There are also unfibered coils, which we use often. That's an Amplatzer plug, liquid embolic agent, in this case onyx. That's a covered stent, Avitene on the left and gel foam on the right, both of which could be temporary and revascularized potentially. It's not guaranteed. And that is particle embolic agent. That is pretty much permanent and would not revascularize. When to phone an IR friend. So traumatic injuries to the liver, spleen, pelvis. These are the mainstays of IR trauma intervention. But also traumatic injuries to kidneys, lungs, extremities, pancreas, adrenals, nearly all vascular injuries that can wait 30 minutes. Often we're not in-house in many hospitals, and we are within 30 minutes of reaching the hospital. So let's talk a little bit more about splenic embolization. Indications. In the hemodynamically stable patient with splenic trauma treated with non-operative management, you should consider splenic artery embolization for AAST grades 3 to 5, active extrav on CT, moderate hemoperitoneum, or clinical evidence of ongoing bleeding. Some general principles of splenic artery embolization. If the splenic injury is too great, hemostasis may not occur on its own because perfusion pressure is too high. We can embolize proximally in the splenic artery, which would decrease perfusion pressure by about 40 millimeters of mercury, allowing hemostasis to occur. Or we can embolize distally in a subselective branch, which would produce stasis completely, perfusion pressure dropping to 0 because the spleen is an end organ. More often than not, we are embolizing proximally. We consider a distal embolization if there's a focal vessel injury that we can subselect. We rely on collateral perfusion to the spleen because, as the previous slide mentioned, we're really trying to decrease perfusion pressure. So we're targeting the middle 1/3 of the splenic artery in between the dorsal pancreatic and pancreatic magna arteries so that there is continued perfusion to the spleen. So that's the dorsal, the transverse, and the magna. And then we also rely on short gastrics and the gastroepiploic. An example. So this was a grade 3 injury seen on CT, which is less well appreciated on the angiogram. Here we're looking at the angiogram, so it'd be difficult to grade here, but what we see is that there's significantly decreased perfusion to the upper portion of the spleen. Additionally, there's a focal pseudoaneurysm. In this case, we used a microcatheter to select the vessel that was supplying the pseudoaneurysm. You can see it there, pointed by the arrow. We embolized that vessel. That's the embolization coil. And then we also embolized proximally in the splenic artery. And this is the post-intervention angiogram showing that there is no contrast flowing beyond the coil pack. So what can possibly go wrong? Complications. The Western Trauma Association did what is probably the largest trial of about 140 patients, showing that 21% had splenic infarcts, 11% had continued bleeding, 5% required splenectomy because of continued bleeding, and 3% developed a splenic abscess. Should you vaccinate after splenic artery embolization? So in a study examining splenic function after proximal splenic artery embolization, 92% of patients had normal splenic function as measured by presence of Howell-Jolly bodies, which the functioning spleen should remove. 100% of patients had appropriate immunity to H. influenza. 94 patients had appropriate immunity to S. pneumonia. Despite encouraging results, however, vaccination is still recommended, but almost nobody actually does it in practice. Moving on to liver embolization, indications, active extravasation on CT in a hemodynamically stable patient. Any degree of liver injury can be treated with embolization. Angio can be first-line intervention for a patient who's a transient responder to resuscitation as an adjunct to potential operative management. IR can also help with additional complications related to liver trauma, like a pseudoaneurysm, fistula, arteriovenous, arterioportal, arteriobiliary, bile injury, bile leak, hepatic vein injuries. Some general principles. The liver is extremely tolerant of arterial embolization due to its dual blood supply. Despite this, unlike splenic artery embolization for liver embo, we try to be as subselective as possible, allowing for patient condition and technical limitations. We would use coil embolizations in a subselective fashion for peripheral hepatic artery injury, like active bleeding, pseudoaneurysm, or fistula. We would use a stent graft in a more central arterial injury, like active bleeding, dissection, pseudoaneurysm, so proper hepatic, common hepatic. And in hepatic vein injury, we can also embolize, but if possible, we would deploy a covered stent. And for biliary interventions, we use a drain, PTHC for bile leak, or percutaneous drains for biloma. An example, this was a 9-year-old boy, blunt trauma to the chest and upper abdomen from motorbike handlebars. What we're looking at is a CTA. You see here there is large hemoperitoneum, but also a pseudoaneurysm in the left lobe of the liver. This is a little bit more caudal slice on the same patient, same exam. And what we're looking at here is during this very good arterial phase, you see opacification of the left portal vein. That indicates an arterial portal fistula. This is the angiogram. On the left-hand side, you can see that the catheter is positioned in the proper hepatic artery. And on angiogram, you can see the pseudoaneurysm that we saw in the prior CT. On the right side, we're looking at the same study, catheters in the same position. It's the same injection of contrast. This is only about a half a second later, and you see immediate opacification of the portal vein, indicating that we are confirming the arterioportal fistula that we saw on CT. Here we deployed a microcatheter into the pseudoaneurysm, injected a little bit of contrast, and confirmed that our microcatheter is in fact in the pseudoaneurysm. We embolized the pseudoaneurysm, filled it with coils, did another angiogram, and showed that there's no further opacification of the pseudoaneurysm. Here we moved on to identifying where the arterioportal fistula is. In this case, we found that vessel, did an angiogram, and you can see very subtly that there's opacification of the left portal vein here when we inject the small vessel. We embolized that vessel. Sorry, I'll go back. We embolized that vessel, and there is no further portal opacification. So what can possibly go wrong? Complications, bile leak, hepatic necrosis, abscess, gallbladder infarction. Most complications can be treated with non-operative management, percutaneous intervention like drains, PTHC, or endoscopy. Liver-related mortality after liver embo is about 6%, with all-cause mortality following liver embo at less than 10%. Pelvic angiogram. Indications. Pelvic fractures with hemodynamic instability or signs of ongoing bleeding after non-pelvic sources of blood loss have been ruled out. arterial extravasation on CT should be considered for pelvic angio regardless of hemodynamic status. If there are signs of ongoing bleeding after pelvic angio, another angio should be considered. And for patients over 60 with major pelvic fractures, a pelvic angio should be considered regardless of hemodynamic status. Some general principles. So when there is a pelvic fracture and a pelvic hematoma, the source of bleeding can be from the bone, vein, or artery. Angio is only indicated for arterial injuries. Most commonly injured pelvic arteries: superior gluteal, internal pudendal, lateral sacral, and the obturator. What we're looking at here is a 3D model in an LAO view. There's an extremely rich collateral arterial network to the pelvis, which makes it very forgiving of non-selective embolization. In the unstable patient, it's totally acceptable and safe to non-selectively embolize both internal iliac arteries. Typically, we can at least localize laterality to the side of fracture or the side of the large hematoma, and even potentially to the anterior or posterior division of the internal iliac artery. An example: blunt trauma to the pelvic, complex fracture, we see active extravasation. This is a CTA. There's a pigtail catheter here above the iliac bifurcation. This is a pelvic angiogram. And what we see is a small pseudoaneurysm that corresponds to the active bleed we saw in the CTA. We exchanged, looking on the left-hand side here, we exchanged the pigtail catheter for a sauce catheter, used it to select the right internal iliac artery. Very nice injection, but we do not see the pseudoaneurysm that we saw on the prior angiogram. Looking at the right image, which is basically the same injection, but a couple frames forward, you see contrast refluxing going down the external iliac, and suddenly you see very subtly the pseudoaneurysm that we saw with the pigtail. So that suggests that the pseudoaneurysm is opacifying from a vessel coming off the external iliac. In this case, we found that this person has a corona mortis, normal variant. We selected that, actually got access on the contralateral side, went up and over the iliac bifurcation, used a microcatheter to select the corona mortis. And in fact, you can see here that there's the corona mortis. The pseudoaneurysm opacifies quite nicely. Couldn't get beyond the tortuous portion of the proximal vessel, and so used avatine, which is a very small particle embolic agent, to go distally and embolize and occlude the pseudoaneurysm, which you can see here. That is the vessel, but it does not opacify distally. And you can see a little bit of contrast that's residually retained within the pseudoaneurysm, but that was not opacifying during this injection. That was just some leftover from the prior injection. So what can possibly go wrong? Some complications. Overall safety of pelvic embolization is very well established. Non-target embolization is the primary complication, but this can be avoided with careful technique. Sexual dysfunction in males does not seem to be impaired even after bilateral internal iliac artery embolization. In practice, as I mentioned before, bilateral internal iliac artery embolization is rarely performed. Gluteal necrosis can be theoretically minimized with technique, again, as long as you don't embolize both internal iliac arteries completely. Typically, this would be theoretically minimized. But it's been shown to be probably related to trauma to the gluteal region and prolonged hypotension rather than a direct complication of embolization. Some additional examples where IR can be helpful. In this case, on the left-hand side, we see an intercostal artery with a pseudoaneurysm. On the right-hand side, we see that there's a pseudoaneurysm, some coils down, and there's no further opacification of the pseudoaneurysm. The leftmost image, right there, we see a large breast hematoma with some active extrav. That's an arterial phase CT. Active extrav centrally within the hematoma. Here we're looking at a pseudoaneurysm and bleed from the right subclavian artery. That pseudoaneurysm was embolized, no further bleed from the subclavian. In this case, we're looking at the profunda. There is a bleed and pseudoaneurysm arising from the profunda. A covered stent was placed across the defect, and post-intervention angiogram shows that there's no further bleeding nor pseudoaneurysm. Here we see a pseudoaneurysm in the right lung. This pulmonary artery was selected. You can see opacification of the pseudoaneurysm. It was coiled and no further opacification. In this case, it's pelvic trauma and trauma to the calyces with extravasation of urine in the collecting system. This is a delayed phase, as you can see the contrast in the collecting system. On angiogram, we have a catheter in the proximal renal artery with a microcatheter deployed selecting a right lower pole branch that shows the area of active extravasation that was successfully embolized. And then you see a little bit of contrast that looks a little shaggy in that right image. That's just parenchymal opacification. Here we can see contrast during a hepatic venous phase, opacifying the subphrenic region. A hepatic venogram shows, again, contrast is extravasating. A covered stent was deployed, and post-intervention venogram shows that there is no further opacification. In conclusion, while the spleen, liver, and pelvis are the mainstays of IR trauma intervention, basically if a vessel is injured, we can often be of assistance. If you're not sure if we can help, just ask. All we ask for in return is 30 minutes time to show up. I encourage you to please email me with any questions. That's my email, and that is my talk.